Hello, good afternoon. Hello. Today we'll be studying about menopause. Let me check the audio and video. Good afternoon. Hello. So let's start the discussion. Defining menopause. Menopause is derived from a Greek word that is men, that is month, and pauses, that means cessation. And menopause is a point in time that follows 1 year after complete cessation of menstruation or time of the final menstrual period, which is followed by 12 months of amenorrhea. And that means a woman, after a final menstrual period, she should not be having 12 menstruation for 12 months. So this is a retrospective diagnosis that can be made. So according to WHO, it is permanent cessation of menstruation resulting from the loss of ovarian function or ovarian follicular activity. And menopause is a continuum, is a 1 point continuum in the different life stages for the woman, which marks the end of the reproductive age of the woman. And also, it is usually beyond the age of 45 and 55 years. And this is a natural part of biological aging. That is, according to WHO, this is a natural part of aging, and it only usually occurs from 45 to 55 years of age. So the natural age of menopause is more than 40 years, and the median age is 50 to 52 years. And according to Massachusetts Women's Health Study, it is 51.5 years, whereas according to study of women health across the nation, SWAN, it is 51.4 years. In Nepal, the average age of menopause is 48.7 years. The early menopause is a natural it is a natural menopause if it occurs between 40 to 45 years of age, and it can occur in 5% of women. Similarly, premature menopause is the one which occurs when there is a permanent loss of ovarian function before the age of 40, especially like in case of surgical menopause, like in bilateral oophorectomy. And primary ovarian insufficiency (POI) is defined as a loss of ovarian function before the age of 40 years, which may not be permanent, and it occurs in 1% of women. Postmenopause is years following menopause. Delayed menopause if menopause has not occurred by the age of 55 years or more, and if premature ovarian failure is if the cessation of menstruation occurs before age of 30, and it is usually associated with elevated follicle stimulating hormone and other variable causes, and we will describe it in our upcoming slides. There is a term called perimenopause and also climacteric, which is the old term which is now preferred as menopausal transition, and it refers to the late reproductive age of late 40s and early 50s, which is also it is menstrual menopausal transition. So defining menopausal transition, it is also a progressive endocrinological continuum uh, that takes place in the reproductive age group woman, which in which there is a transition from regular cyclic menses to a final menstrual period and ovarian senescence. This is a period, and it usually begins with the irregular menstruation cycle and extends up to 1 year after the permanent cessation of menses, that is from the FMP to menopause. And it has a wide range from 42 to 58 years of life, and average age of onset is 47 years, and the duration is usually 4 to 7 years. So this is the uh, classification done by Straw, that is stages of reproductive age group aging workshop, which divides the woman's life into different stages -5 to +2, and minus up to -3 is reproductive age group. And from -2, the perimenopausal or menopausal transitions occur, and usually -2 is early menopausal transition, in which the menses are variable, and here there is usually the irregular cycle length, that is, it will be increasing to 7 days or more, and from the normal. And in the late menopausal transition, that is in -1, there will be more than or equal to two skipped cycles, and there is an interval of more than 60 days. So, and then 0 is regarded as the final menstrual period, which is also known as FMP, as we say LMP. And then there will be stage +1 and stage +2. +1 is again divided into +1A and +1B. 2 is all lifelong throughout the menopause. In early menopause, that is +1A, it lasts for 1 year, which shows the early menstrual problems, and then the remaining is for 4 years. So the same thing, the staging of reproductive aging workshop says that the late reproductive stage is marked by decreased fertility and onset of menstrual cycle changes. In early menstrual menopausal transition, that is in -2, the woman's menstrual cycle remain regular, but the interval between the cycles may be altered by 7 or more days, and the cycle length becoming shorter. And in this case, FSH levels are increased, and serum estrogen also may be increased in early follicular phase. And in late menopausal transition, that is in stage -1, it is characterized by two or more skipped menses, or at least one instrumental intervention interval of 60 days or more due to longer and longer period of anovulation. And menopausal, that is +1 to +2, is early menopausal of 4 years after the final menstrual period, and followed by late menopause. And in this case, there will be a hormonal change, typical hormonal change, that is increase in FSH level, reduced ovarian antral follicle count, declining level of inhibin B, and anti-Mullerian hormone accompanying the menstrual changes. So we will be detailed discussing about these two phases. Now, symptoms that are present in this is a chart that I have taken from Williams Gynecology, and in this there are symptoms associated with the menopausal transitions are of regarding the menstrual period or menstrual cycle. There will be shorter cycle or longer cycle or irregular bleeding, and in vasometer changes there will be hot flushes, also known as flashes, sweating, sleep disturbance, and psychological or worsening of premenopausal syndrome, depression, irritability, anxiety, mood swings, poor concentration, poor memory, and there will be sexual dysfunction due to vaginal dryness, decreased libido, dyspareunia, and also somatic features like headache, dizziness, palpitation, breast pain, enlargement, joint ache, and back pain, and others like urinary incontinence, dry, itchy skin, and weight gain. So, what are the factors that affect menopause? There are different factors that affect menopause, like environmental factor, the climatic changes, the genetic changes that usually a woman with in whom the mother or a first degree relative has early menopause is susceptible for early menopause, surgical influences, chemotherapy, radiotherapy, uh, ovarian surgery, they all hasten the menopause. Similarly, smoking increases decreases the age of menopause by approximately 2 years. Diet, exercise, body mass index, reproduction history, socioeconomic status. Usually, low socioeconomic status women are having early menopause, and also there is a individual or cultural attitude toward menopause affected symptoms. In many societies, the symptoms that occurs after menopause are considered normal, and they do not come into contact with the physicians for the problems. And alcohol has found to increase the estrogen production and also increase the delay the menopause. Similarly, in thinner women, menopause is menopause occurs earlier comparatively in some studies. So, going with the natural uh, mechanism of physiology of menstruation in women of reproductive age, in early reproductive age, there is a pulsatile release of GnRH hormone from gonadotropin releasing hormone from hypothalamus that will stimulate the anterior pituitary, causing the release of luteinizing hormone and follicle stimulating hormones, which stimulate the ovarian follicles, graphene follicles, to produce estrogen along with the corpus luteum, which secretes the progesterone, and also there is secretion of testosterone, and the follicular cells also secrete inhibin B. Inhibin B is the regulatory hormone that will inhibit inhibit the release of LH and FSH. Similarly, the combination of estrogen and progesterone uh, exerts a positive and negative feedback mechanism with the simultaneous changes in uterus. But in the woman with a late menopausal transition state, what happens is the follicles usually there is decreased follicles numbers and also altered follicogenesis. So there is increased incidence of anovulation, um, and also there is accelerated loss of follicles, and the pathology is there is decrease in inhibin B, which had a negative feedback mechanism. So the negative feedback mechanism is lost, and there is increased follicular stimulating hormone. Similarly, anti-mullerian hormone is a glycoprotein that is secreted by the granulation cells of secondary and pre-enteral follicles, and it indirectly reflects the primordial follicle pool. So, decreasing in AMS level progressively means uh, the patient is approaching menopausal transition, and also with ovarian failure, that is the menopausal transition stage plus 1B, there is a release of also the ovarian hormone releases ceases, and all the negative feedback is open, and so the GnRH, which was released in which was released in pulsatile manners, now gets released in maximum frequency and amplitude continuously, and similarly there will be increase in follicle stimulating hormone and luteinizing hormone up to fourfold than of the reproductive years. So because of the increase of follicle stimulating hormone, also there is a fluctuation of production of estradiol, and they will uh, also increase in the concentration, and in late late menopausal transition phase there will be decrease in level of estradiol, and estrogen is the main estrogen during menopause. Also the progesterone levels during the early menopausal transition are lower than in mid-aged reproductive age group women, and androgen diet is also decreased by 50%. Testosterone level remains similar, whereas due to decrease in sex hormone binding globulin, there will be relative excess of free unbound estrogen and testosterone initially. The adrenal steroid levels are in women in 70 to 80 years of age. There will be dihydroepiandrosterone sulfide levels are diminished by 74% to 1.6 micromole per liter, and other adrenal hormones also fall with age. The androgen hormone peaks by age of 20 to 30 years and then declines 62% in 50 to 60 years. These are all the steroid hormones that are produced by adrenal gland, and pregnenolone is also decreased, and the ovary so the contribution of ovary during for production of these hormones are also decreased after menopause. So only the adrenal gland is responsible for the synthesis, and these hormones will be converted into estrogen in adipose tissue with the help of enzyme aromatase, so as to maintain a balance. So this is a picture, as we have already said. From the ovary, there will be decrease in production of estradiol, decrease in production of inhibin. So there is decrease of negative feedback to hypothalamus, and increased release of CNRS, increased release of FSH, and increased release of LH. Similarly, increased release of androstenedione from no, there is a decreased release of androstenedione after menopause, whereas the adrenal gland produces androstenedione and sulfide and testosterone, and these get uh, aromatized in adipocytes into estradiol and estrone. So these are all the hormones that are available in menopause. This is the label. This is the picture showing label among the hormones. Estradiol level is also decreased. Estrogen is the major concentration. Testosterone remains similar, whereas androstenedione also decreases similarly. In steroids, uh, we can see that estrogen level has decreased significantly, and other are almost similar, decreased. All the except testosterone, all hormones are decreasing. So this is a typical label, and FSS more than 40, LS 50 to 100, and estrogen, estradiol 5 to 25, estrone 20 to 70, low inhibin B, low antimullin hormone. These are all the diagnostic features. So discussing about the physiological changes, starting from ovaries. As you have already said, there will be accelerated follicogenesis and follicular breakdown in woman lifetime. The maximum number of oocytes is during 20th week of gestation, that is 6 to 7 million oocytes, and then that becomes 1 to 2 million oocytes during birth. And every menopausal in every menstrual cycle, one follicle become dominant, but many follicles are activated and get degenerated. And in even lifetime, women may experience about 400 ovulatory events. So, virtually at the start of late 30s or early 40s, the ovary become devoid of follicles, and these follicles are replaced by fibrous tissues. So they have a volume divide of follicular tissues, and then this whole process is not dependent on pituitary. So as you can see, in the reproductive age group, the ovary have predominant primordial follicles, which are developing in different stages for release of oocytes. But the menopause ovary shows atretic follicles with persistent corpora albicans. Now the vaginal changes because there is a decrease in estrogen level. The vaginal epithelium has changes. Atropic changes occurs in vagina uh, with so that it shortens, narrows, lose flexibility because of decrease in due to loss of collagen, adipose tissue, and water content. And also, it becomes a predominantly basal and parabasal cells with maturity index of 100 is to 0 is to 0 due to hypoestrogenic state. And also, there is a thin vaginal mucosa which becomes friable and prone to bleed even with minimal trauma. And there are the changes resulting from estrogen deficiency which lead to inflammation resulting in atrophic vaginitis. And the vaginal mucosa becomes thin, shiny. The ruga are flattened. pH will increase beyond 4.5 and less lactobacilli and susceptible to infection. So endometrium in early menopausal transition, endometrium will show the ovulatory pattern, whereas in late menopausal transition, the anovulatory cycles are present. That is, estrogen effect is occurring, which is unopposed by progesterone. So there will be proliferative changes or disordered proliferative changes, which are frequent findings in during menopausal transition. Similarly, menopausal atrophic endometrium occurs, uterus becomes atropic, and during menopausal, there might be fluctuating levels of estrogen during which there will be irregular breathing, which can be either usually anovulatory and sometimes ovulatory also, and will lead to dysfunctional uterine bleeding, endometrial hyperplasia, and endometrial cancer. The menstrual disturbances are usually abnormal uterine bleeding, which is irregular menses in half of the women. The anovulation is the most common cause because there is relatively high estrogen level and low progesterone. There will be anovulatory bleed. Sometimes ovulatory cycles can occur, which lead to unexplained pregnancy, and contraception can be discontinued by all women at age of 55. And endometrial hyperplasia, polyp, leiomyoma will occur, and endometrial carcinoma in which AUB is in menopausal transition of 10%. So, how do we manage the AUB of perimenopausal state or means menopausal transition? Is if there is no any organic disease, the management will depend on the age of the woman and endometrial tissue findings. So, if there is simple endometrial hyperplasia that is uncomplicated by atypia or dysplastic constituents, then periodic oral progesterone therapy is mandatory, uh, such as 10 mg medroxyprogesterone acetate or 5 to 10 mg norethindrone acetate for 14 days each month. Then intrauterine placement of levonorgestrel intrauterine device. Then higher dose of oral progestins can be given in case of obese. And the progesterone response is better with higher dose and longer duration of treatment. And if histological regression doesn't occurs, estrogen not occurs, and the office biopsy is done, DNC should be done before hysterectomy. If there is simple hyperplasia, then repeat endometrial Sampling should be performed at 3 months and 6 months of therapy, and most cases will regress within 6 months. And if there is no regression within 3 to 6 months, then we can increase the progesterone, or we can switch the regimen, such as a measured state of daily doses of 40 to 80 mg or levonorgestrel IUD. But even with medical management, there can be persistence of or progression of abnormal endometrium to complex hyperplasia or atypical hyperplasia. Mm, to say negative, at least two negative biopsies should be conducted. And if the regression doesn't occur after 1 year of radiation therapy, or there is a conversion from simple to complex without atypia to atypical hyperplasia, despite the radiation therapy, then hysterectomy is indicated and referred to gynecologic oncologist. And because hyperplasia with atypia carries with the risk of concomitant cancer, hysterectomy is a treatment of choice. And also, existence into estrogen without contraceptive dose of progesterone when a woman is not amenorrheic or experiencing menopausal symptom is risky because it would expose the endometrium to estrogen, unopposed estrogen, which will lead to estrogen hyperplasia, sorry, endometrium hyperplasia. And the postmenopausal hormonal regimen that we are given that consists of progesterone only is not sufficient for contraception. So, mm, regulating the anabolic cycles with monthly progesterone treatment along with appropriate contraceptive measures. This is a normal oral contraceptive of 20 microgram estrogen will provide effective contraception, improve menstrual cycle, and diminish bleeding, and also relieve the menopausal symptom and levonorgestrel IUD is better choice. Also, in a perimenopausal or postmenopausal woman, if there is ovarian cyst or any adnexal mass, it will be taken as cancer until proven otherwise. There might be non-bulbable asymptomatic ovarian cyst in USC, which are less than 10 centimeter without septation or solid composite simple cyst. They have very low potential for malignant formation and can be managed with serial ultrasound in 3, 6, and 12 months, and then yearly. And serum CA125 should come normal, but surgery is recommended for symptomatic cases. And also, the growth occurs if internal echoes are obtained and fluid develops in the pelvis, and if there is family history of breast or ovarian cancer. Now, the central thermoregulation. The thermoregulation of our body is controlled by hypothalamus and special center, which is known as thermoregulatory zone. And during perimenopausal and postmenopausal vasomotor symptoms are due to the alteration of thermoregulation, and it occurs in terms of hot flashes, hot flushes, or night sweat, which occurs in 11 to 60% of menstrual women during menopausal transitions, and it is more associated with low exercise levels, smoking, high FSS, and low statile level, increasing BMI, ethnicity, low socioeconomic status, and prior premenstrual dysphoric disorders or depression. So, in the women who have a narrower region of hypothalamic thermoregulatory zone of hypothalamus, the minimal change in the core body temperature will cause shivering and hot flush, and also the various hormones and neurotransmitters are released, which cause the imbalance because there is estrogen deficiency or estrogen sudden fall. So there will be fall in inhibitory presynaptic alpha-2 adrenergic receptors, and also there will be uh, increase in serotonin and norepinephrine in hypothalamus. So this will lower the set point of thermoregulatory zone, and then the heat loss mechanism will be triggered with subtle change in body temperature. And also we are utilizing these mechanisms by using serotonin uptake inhibitors, nor uh, not just inhibitors. So, what is hot flash or hot flush? It is a sudden increase of temperature of the body with reddening of skin over the face, head, neck, chest, especially upper body, and also the fingers and toes due to the increase of temperature, accompanied by the increase in heart rate, and also there will be a feeling of intense body heat that spreads of the body, and the skin temperature might increase up to 10 to 15 degrees due to vasodilation. Heart rate will increase by 7 to 15 beats per minute. The metabolic rate also rises, and there will be peak blood flow uh, within 3 minutes, and then there will be profuse perspiration with core temperature decline by zero point 0.1 to zero point 0.9 degrees centigrade, and heat loss will occur and screen temperature becomes normal with sweaty. So the duration may last from few minutes, seconds to minutes to rarely an hour. The frequency may be rare or recurrent, which will affect the day-to-day life of a woman, and they are more frequent and severe at night when a woman is awakened from sleep or during the time of stress. So there will be also the increase in blood pressure with hot flashes, and it can be accompanied with palpitation, anxiety, irritability, panic, and this plus coordinates with LHRs. So the management is lifestyle modification like avoiding the trigger factors like stress, caffeine, alcohol, spicy foods, beverages, avoiding smoking, cooling rooms, light clothes, dressing in layers, consuming cool drinks, and also some relaxation techniques, acupuncture, yoga, other non-hormonal agents, simple agents like pregabalin, gabapentin, and clonidine, SSRI, SNRI. So there is a selective serotonin reuptake inhibitor like paroxetine, fluoxetine, escitalopram, sertraline can be used, and selective non-epinephrine reuptake inhibitor can also be used. And benzodiazepine is FDA approved drug that contains of a mixture of conjugated estrogen with selective estrogen receptor modulators, and so it will act as estrogen agonist and antagonist depending on the tissue affected, along with antagonist effect on uterine tissue to prevent the endometrial hyperplasia. The other drug is tibolone, bezidoxifene, tibolone. Tibolone is here, that is selective tissue estrogen activity regulator. So, so for vasomotor symptoms, if it is severe enough to affect the day-to-day life of woman, we might need to prescribe the hormone replacement therapy, which consists of estrogen, and usually systemic estrogen are effective for moderate to severe vasomotor symptoms. Oral, parenteral, transdermal, topical, any routes can be used, and with standard dose. But in younger person or with recent oophorectomy or surgical menopause might need higher dose, and they need to be gradually tapered. Progesterone are also effective, and there might be adverse effects like abnormal vaginal bleeding and weight gain, and there is no benefit in adding testosterone alone except protection against endometrial hyperplasia. Now, osteoporosis. Osteoporosis is defined as a skeletal disorder that progressively reduces the bone mass and strength in the trabecular bone and leads to higher fracture rate. The decrease in the bone mass and strength. And postmenopausal women from 40 to 50 now will experience 40 to 50% will experience the osteoporosis and related fracture in lifetime. The bone mass will decline at a slow, steady rate of 0.4% each year after adolescence, and in the absence of hormone therapy during menopause, their rate rises 2 to 5% and 1% per year. So the mechanism, the normal mechanism of remodeling of the bone is controlled by osteoclast and osteoblast. Osteoclast are the cells, the macrophagic cells of bone that are responsible for bone resorption, whereas osteoblasts are the cells that are responsible for laying the osteocytes or bone cells. These are the osteoblast cells that will form the mature oocytes and osteoids, and also osteoblast is responsible for synthesis of two or two structures. One is rank rank, and the other is osteoprogenitin. These are both the structures that are responsible. And also there are the osteoclastic cells, and osteoclastic cells have rank ligand, which will bind with the rank produced by osteoblast, and this will lead to activation of osteoclast and will cause more and more bone resorption. So in menopause, what happens is there is and this osteoprogenitin is a structure that will bind with rank ligand and prevent the more and more activation of osteoclasts, and as a whole there will be a balance in remodeling and balance in laying of the bones and resorption. But in menopause, after menopause, what happens is the estrogen level is less, and so there will be the decreased production of rank ligand, and also there will be increased production of rank ligand and decreased production of osteoprogenitin, and thus this will not be able to bind, and there will be free rank ligand which will bind with uh, rank in osteoclast, and they will activate the osteoclast, leading to more and more bone resorption. And also and will increase the rank ligand expression and outnumber the osteoprogenin. So it's the same thing. And also there will be decrease in dietary calcium, decreased absorption from the gut of calcium, and also there will be stimulated parathormone, which will lead to osteoclastic activity. The risk factors are non-modifiable like age, race, small body frame, early menopause, prior adult fracture, family history, osteoporosis. Inadequate modifiable like inadequate intake of calcium and vitamin D, uh, smoking, low body weight, excess alcohol use, sedentary lifestyle, and the other associated medical conditions like hyperthyroidism, hyperparathyroidism, chronic renal disease, rheumatoid arthritis, systemic steroid use, and innovulation during reproductive years. So, how will we diagnose? The diagnosis is done by DEXA scan, that is emission, dual energy X-ray absorptiometry, in this one for hip and spine, and bone mineral density is measured. So, the WHO criteria for diagnosis of osteoporosis based on bone mineral density is on the basis of T score, which compares the bone mass of patient with young adult bone mass, and the normal is deviation of 0 to -1 standard deviation. If it is -1 to -2 standard deviation, then it is known as osteopenia. If less than or equal to -2.5 standard deviation, then it is osteoporosis, and if severe osteoporosis when there is less than -2.5 standard deviation plus fractures. So, how can we prevent osteoporosis? We will need to counsel the risks of osteoporosis to the menopausal woman, which check for secondary causes, and any woman for 50 and older. Encourage diets rich in calcium and vitamin D, and if not sufficient, add supplement. Balance calcium, add some vitamin D. And there will be regular weight bearing and muscle strengthening exercise, no tobacco or alcohol. Fall risks should be assessed and modified. Height measured annually, and one more than 65 years of age. We can recommend bone mineral density testing in new factor. Also, we'll recommend BMD testing to determine the degree of disease severity for patients on pharmacotherapy. We can perform bone mineral density testing 2 years after basic therapy and every 2 years thereafter. So, what are the treatment options? There are prevention options and treatment options. Treatment options that will act on osteoclast and that will act on osteoblast. So, acting on osteoblast and helping in laying the bones is teraperatite and strontium renylate. Teraperatite, and renylate. Strontium renylate. Strontium renylate. And acting on osteoclast and preventing bone resorptions are bisphosphonates, estrogen, selective estrogen receptor modulators, calcitonin, and denosumab. So calcium supplement, we need to provide a positive calcium balance for women from 31 to 51 gram, 1000 milligram, and more than 51 years, about the same milligram. And calcium preparations like calcium carbonate, calcium lactate, calcium citrate, and calcium gluconate. And the best is calcium citrate as it doesn't require gastric acid for absorption, and it can be taken with meal, single dose, maximum 500. And they will be important, but the calcium supplement cannot provide the same degree of protection as hormone replacement therapy. The vitamin D, usually the active vitamin D, cholecalciferol, is required, and it uh, decreases the threefold risk of vertebral fracture, and we will need to monitor vitamin D3 level. If it is below normal or vitamin D deficiency, replacement should be done. And also the calcium supplement, bisphosphonates are the drug of choice, first line of choice, because they will enhance the osteoclastic apoptosis and also suppress the osteoclast precursors and reduce the risk of fracture by 30% and increase bone density of spine and hip. Erinranate, zolinranate, ricidronate, the adverse effect are it can cause oral ulcer, esophagitis, arthralgia, diarrhea, osteonecrosis of jaw, and atypical femur fracture. Selective estrogen receptor modulators are the drugs available are tamoxifen, relaxin, indoxafen, ospemifene, and different effects are in these are due to different receptors, different receptor effects. Like in tamoxifen, relaxin, indoxafen, ospemifene. Different effects due to different receptors like agonist in CES, bone, and antagonist in breast and fetus. The advantages are it will reduce the incidence of breast cancer, it doesn't proliferate the endometrium, it will reduce the vertebral fracture by 50%, and it will also reduce the triglyceride, cholesterol, and raise HDL, which is cardioprotective. The side effects are hot flushes and pressure-like symptoms, leg cramps, venous thrombosis, and increased incidence of retinopathy. Some parathyroid hormone receptor antagonists like teriparatide and abaloparatide can be given. These activate the osteoblastic bone formation by activation of parathormone receptors. In low and pulsatile parathormone will help in bone formation and but excess will cause the resorption. It is given as subcutaneous injection for 2 years and it is FDA approved for postmenopausal women. There is risk of osteosarcoma. Calcitonin will regulate the calcium and phosphorus in body by opposing the parathormone effect, and it increases the calcium in blood by inhibiting the osteoclastic activity and promoting the calcium deposition in bone, and it will also uh, inhibit the renal tubular reabsorption and intestinal reabsorption and decrease calcium in blood. And calcitonin is a synthetic calcitonin which can be used as nasal spray, can cause nausea, gastritis, rhinitis. Denosumab is a monoclonal antibody which will bind with rank ligand, and so the osteoclastic activity development will be inhibited and decrease bone resorption. And sclerostin inhibitors like romosozumab bind to sclerostin and it will inhibit the activity of protein sclerotin, which inhibits the activity of osteoblast, and there will be osteoblast will function and increase the bone formation. Sclerostin is a protein which inhibits the activation of osteoblast. Sclerostin. Now, cardiovascular effects, as already estrogen will increase high density lipoprotein, decrease LDL and total cholesterol. It also inhibits the platelet and microbial foam cell aggregation. It stimulates the nitric oxide and prostacyclin, which will cause to paralysis of our blood vessels and prevent atherosclerosis. At the age of 70, usually the congenital risk of MI is a woman is 10 years younger than a man for MI, but at the age of 70, it becomes same. Prevention, walking and exercise, weight reduction, reduction of trunk obesity, dietary modification, lipid lowering drugs, and estrogen. Central obesity is common in postmenopausal women. Skin changes like hyperpigmentation, wrinkling, itching. It is due to the synergistic effect of intrinsic aging and photoaging, and also the hormonal aging, which is which causes the decrease of thickness as there is a lower collagen content and diminished sebaceous gland secretion, loss of elasticity, decreased blood supply, dental changes due to decrease in level of estrogen buffer into decreased saliva and chances and fat distant mouth, increase in incidence of cavities and tooth loss or alveolar bone loss, breast change at menopause due to estrogen and estrogen. There will be reduction of volume production. Mm, there will be reduced density of volume and tissues, glandular cells, decreased fat, increased pendulous, and mammography. There will be replacement of replaced with adipose tissue. Mammography is advised for women older than age 40. Now, CNS, there will be sleep dysfunction and fatigue. That the quality will decline, frequent awakening, sweating, hot flushes, insomnia, menstrual symptoms, light sleep with idiom, awakening, nocturnal urgency, frequency, sleep disorder, breathing, loud snoring, fatigue, elevated, uh, and all these will lead to mood disorders, decreased cognitive ability. So, method of prevention: adequate sleep every night, exercise regularly, avoid long work hours, maintain procedure, personal schedule. If stress is environmental, vacations with jobs, approach for help, limit intake of alcohol, drugs, nicotine, healthy, well balanced diet, drink adequate amount of water during early part of day, and if not successful, menopause specialist. Cognitive dysfunction. There will be libido change as menopause. There is a vaginal change, narrowing of intercourse, dyspareunia, and also sexual response. The feeling for one partner change, stress, other social factors. So there will be loss of libido and also orgasmic dysfunction. And there is a combined trauma known as GSM, genital urinary syndrome of menopause, which is characterized by which occurs in late menopausal phase, characterized by genital dryness, poor lubrication, dyspareunia, postcoital bleeding, poor arousal, orgasm, or desire, follow vaginal irritation, burning, itching, dysuria, urgency, frequency, and signs like labia minor, absence, narrow uterus, absent terminal sacs, tissue pallor, erythema, urethral eversion, urethral prolapse, prominent urethral meatus, recurrent UTI, absent rogi, fragile or fissured tissue, petechial hemorrhage, scant vaginal secretion, and poor elasticity. So the management can be done with vaginal lubricants and moisturizers, water-soluble vaginal lubricants, KY jelly, or polycarbophil-based gels. Hormone therapy can be given in the form of systemic estrogen therapy or topical estrogen therapy with minimal endometrial stimulation that can be given in the form of estrogen cream or estradiol vaginal tablet or estrogen containing vaginal ring. And the main there is confirmed endometrial safety, but long-term use is unknown. Winter for vaginal bleeding, osmifene is FDA approved for dyspareunia and GSM, genitourinary syndrome of menopause, and selective estrogen promoters are effective. So, how will you diagnose a woman in her around 50 years? 40 if you comes with a season of menstruation for 12 months, and it will be Appearance of postmenopausal symptoms like hot flush, night sweat, vaginal cytology, showing menstruation level index of at least 10, 85, 5, serum estradiol less than 20, more than 40, three values at weeks interval, then all general examination, including the blood pressure recording, palpation of breast, weight, height, hirsutism, pelvic examination with pap smear, blood sugar, lipid profile, ECG, mammography, pelvic ultrasound, bone density study, estrogen are needed if we want to decide the need of hormone replacement therapy. Then ultrasonography, transvaginal ultrasonography, hysteroscopy, colposcopy, biopsy, and endometrial aspiration period less than 5 mm. Biopsy is not required if moved from 5 mm to 12 mm. Biopsy is advised and need to basis and more than 12 mm, even if there is no bleeding or clinical suspicion is low, that should be done. Dominance of paravasal cells. Hormone replacement therapy is a broad term that describes the use of estrogen for women who have undergone estrogen and combined estrogen and progesterone in intact uterus to prevent estrogen associated syndrome, sexual dysfunction, vascular injury system, prevention of estrogen condition, modernization of therapy, estrogen combination, non-hormonal steroid, steroid. Selective tissue selective tissue regulator. Thank you everyone. I'll see you in next video.